So we are live.
Yes. Yeah.
Good evening, everyone, and welcome to this webinar. I think Bhavna, you have to
Yeah, Bhavna,
start.
please start.
A very good evening, respected dignitaries. Today we are gathered here for Clinical Insights webinar on practical approach to IVF cases sponsored by Corona Remedies. So, first of all, introducing Dr. Anuradha Khar. Dr. Anuradha Khar is the director of Nurture IVF Bangalore. She is currently practicing infertility and infertility related endoscopy at Bangalore. She is honorable treasurer of Karnataka chapter ISAR from 23 to 25. Ma'am, I hand over the session to you.
Thank you, Bhavna. We welcome everyone to this webinar today. We all of us together are going to discuss what we do every day in our infertility practice in our IVF centers. And whatever questions the audience has, they can write in the chat box. Those also will be answered at the end. So I would like to invite our moderators for the day, Dr. Seema Pandey and Dr. Ekika Singh. Dr. Ekika Singh is a fertility consultant and she has won a lot of awards. Champion of ISAR, Wonder Foxian Award. She's got a lot of publications, including in ESHRE. And she's practicing in Mau. And I would also like to invite Dr. Seema Pandey, who's practicing in Azamgarh, Atrolia, and Lucknow. And she has completed her executive committee 2 sessions with ISAR. She, I think, I can't describe her in 1 minute. She has written a lot of books. She has done a lot of research papers. She has even gone and presented in endocrinology conference in USA recently. And she is really inquisitive and research oriented and evidence based, of course. So I welcome our panel experts, Dr. Rajesh, Dr. Sachin, and Dr. Anupama. And I hand over to Dr. Ekika to please invite our experts.
Yeah, thank you very much, Dr. Anuradha. Well, as we know, Dr. Sir's name, Dr. Rajesh Karodia, doesn't need any introduction. It's a webinar based completely on practical aspects, which most of us, specifically even the beginners, the seniors, and my colleagues, we all really sometimes get stuck when these problems come. So I think our experts are the the people whom we really can talk to. We can take take home message. So Dr. Rajesh, the best thing about him, he's a consultant, a teacher, and absolutely a guide for fertility disorders and IVF. Sir is a well-known name, and he's currently attached to Wokad Hospital at Mira Road, and a very good teacher and a very nice person. I have known, and even if, and I have doubt, I think he's the one whom I approach. So I'm sure we are going to learn a lot from you. Welcome you, Dr. Rajesh, for a small series on the clinical insight for some of the IVF cases problem which we see in day-to-day life. Now, I would like Dr. Seema to invite the next expert.
So before I invite our next expert, Dr. Sachin Dalal, I would just like to thank Dr. Anuradha Khar for such a beautiful introduction. I think best ever I had. Thank you, Anu. So I invite one of the excellent brains and intellectual person, Dr. Sachin Dalal, who is consultant gynecologist and IVF specialist with his area of specialization in infertility, evaluation, treatment, laparoscopic surgery. He is interested in obstetrics as well, gynec, the complete package of obstetrics, gynecology, and reproductive medicine. So, guys, anything you can ask Sachin. Welcome, Sachin.
Thank you, Dr. Siva, for the kind introduction.
I would like to invite Dr. Anupama Patil. She is from, we belong to the same state, state of Karnataka. She's a gold medalist from Hubli, and she has done her fellowships in ART. Her area of interest is low-cost fertility treatment and ovarian rejuvenation, endometrial rejuvenation. She's won a lot of, she's written a lot of papers and won a lot of awards, and she's a consultant reproductive medicine in Gadag, Karnataka. Welcome, Dr. Anupam.
Thank you, madam.
So, to begin with, I just can you, Bhamna, can you play these sites? Actually, we have taken 3 topics for the discussion.
For Aikika, before we go into discussion, let's pray for a minute.
Yes, sure.
To
So,
God
Bhavna, can you,
Saraswati.
yeah, can you pray for the goddess Saraswati before we start our session?
Yes, Dr.
So,
Ekika.
yeah, so let's start our session. So, we have kept 3 topics, 3 important topics which we generally face and we want to know more about. One is frozen embryo transfer, what to follow. The second being thin endometrium, how much thin is thin, what to be taken care of. And of course, RIF, recurrent implantation failure, still a mystery to unfold. So, let's take each one of them one by one, and we have few questions from our side which we will ask our experts. And if anyone has any query or they want to know something, they can type in the chat box, which we will try our best to communicate to our experts and get the answers. So regarding frozen embryo transfer, sir, I would like to ask you, what parameters are generally taken into account to decide for FET? So, Dr. Rajesh, sir, if you start, and then we'll ask Sachin and Anupama for their points also.
So there are certain situations which are absolute indication where there is no option, but we have to go for FET. Like suppose if you are going for genetic analysis of the embryos, or maybe we are going for surrogacy, or there are certain abnormal hormonal parameters like progesterone is elevated. There are areas where 100% you have to, if the cycles of donor cycles are matched, not matched, or overlapped with the recipient, in that case also we have to freeze the embryos. So these are the absolute indication where you have to freeze the embryos. There is no option left. But nowadays, what happens? The world is moving towards the best cumulative pregnancy rate out of single stimulation. So we all tend to stimulate hard all the patients because we want to have the maximum follicle output rate. And when the maximum follicle output rate, it may range to 8, 10, 12, 20, 25 also sometimes. So uh, and in that case, it is proven beyond doubt with the recent studies and analysis that if the dominant follicles or the expected follicle count is more than 15, then there is no point in doing fresh transfer. And if the count is less than that, then probably fresh transfer and frozen transfer gives the equal result. So in my practice, I when I stimulate the patient, I decide whether should I go for a fresh transfer or frozen embryo transfer. That primarily depends on what is the look of endometrium, texture of the endometrium, endometrial thickness, vascularity, and not only that, then certain hormonal like progesterone on the day of trigger, I took into the account. Not only that, I do measure serum progesterone 12 hours after my trigger, and based on these two values, and lastly, the number of the oocytes which are retrieved, I take a decision. If the oocytes are more than 13, 14, then I normally defer and I prefer a frozen embryo transfer. In otherwise, if the oocytes is less than 13, 14, and progesterone is my cutoff is 1.2. If it is less than 1.2, the endometrium is good, maybe more than 7 millimeter trilaminar, then I prefer a fresh transfer. Otherwise, I prefer frozen embryo transfer.
Uh, Dr. Sachin, anything you want to add to this?
No, so essentially, all that sir has said, I would concur with what he said. Thing is that my serum progesterone cutoff as per the literature is 1.5, and if I have less than 15 M2 oocytes retrieved, there are no chances of OHSS which is seen, then I would probably go ahead and do a fresh transfer. Otherwise, it's a FET for all.
So, okay, so probably it is the AFC, the number of oocytes on the day of the
Yes,
trigger, which is one of the important factor to be taken into account, whether you want to freeze all or whether you can go for a fresh and a freeze transfer. I mean, you can do a fresh transfer also and you can freeze also for the same patient. So,
right. So if
for sir,
I've got more than 15 M2s, then probably I would not go ahead with a fresh transfer, and I would go with a frozen transfer.
I want to ask one more thing, Sachin, in this. Is it the M2 or is it the oocyte retrieved? Because sometimes if you retrieve 20 oocytes, you might get 12 M2 in them and rest are not
Yeah,
the
sorry.
retrieved.
Yeah,
So,
yeah. The number of oocytes retrieved. Sorry,
okay,
I'm driving.
okay, it's the
So
it's the
just
oocytes.
oocytes
Okay.
retrieved. Yeah, yeah.
So one parameter is what we understood from you and sir. It is the number of follicles, which is the decision factor whether to go for FET or a fresh transfer. Dr. Anupama, do you want to add something to this?
Madam, I would say estrogen level would be more important than the number of oocytes retrieved. I wouldn't go for a fresh transfer if the E2 is more than 1800 on the day of trigger, because it has been found that the endometrium advancement occurs with high estrogen levels.
Okay.
So beyond that, although a definite cutoff has not been given when endometrial advancement takes place with high estrogen levels, but 1500 to 1800, I don't go beyond that to go for a fresh transfer. And progesterone 1.5, and a thin endometrium or a polyp or a hydrosalpinx which is seen during stimulation, or a ET catheter which could not be passed during a mock ET. And if we are going for a fertility preservation or for PTT, endometriosis, adenomyosis, these are the cases I would defer a fresh transfer.
Okay. So,
Hello, Dr. Ekika,
yes,
I
sir.
would like to add something regarding the cutoff, progesterone cutoff. So, actually speaking, if you do the analysis of the various studies regarding the cutoff of progesterone on the day of trigger, it varies from depending on the stimulation protocol. It depends on the what gonadotropin you use. It depends on number of the oocytes which are retrieved. So it is depending on a lot of things. For example, if it is a antagonist long agonist protocol, the cutoff is 1.2. If it is antagonist, 1.5. If it is a microflare, it is 1. Microflare, it is 1.75. For example, it is a HMG, then it is 1.75. If it is a RFSH, it is somewhere around 1.26, something like that. So number regarding the number of the oocytes are more than cutoff, maybe little higher. So who remembers this? So our basic tendency is to freeze all, because undisputedly, if you follow the policy of freeze all, at least it will give us equal result or better result than fresh transfer. Nobody can say that fresh transfer has got better result than frozen embryo transfer. So our tendency is to freeze all, but still we want to take out some cases where unnecessary there should not be any delay unnecessarily. So purposefully, I have kept my cutoff little lower, 1.2. So at least I'm sure that at least I'm not going to, my window of implantation is not going to change. That's the whole idea of keeping the cutoff low.
Dr. Seema, you wanted to say something, ma'am?
Yeah, there were two things. One statement I wanted to make, and there was a question too. First thing, Dr. Rajesh is right, especially for poor responders towards lesser number of oocytes. If we just keep a strict cutoff, and 1.5 is just an arbitrary number. As per recent researches, like 1.5 is for poor responders, till 1.5 is till for normal responders, and 1.9 hyper and pieces they are going in FET cycle, they are even take 2.5. But we have to stop regain our own cutoff, and that should be something like. So my question was to Rajesh and Sachin, that what about FET cycle? The same cutoff are you using in these patients as well?
Yeah, I
The
think that is. Yeah, please,
Are
sir.
yeah,
you before starting the patient you are going to take her for FET cycle, are you doing their progesterones?
yeah, yeah. So suppose I'm going for, nowadays we normally either go for letrozole stimulated cycle or HRT cycle. That may be down regulated or non down regulated cycle primarily. And most of us we do not prefer modified natural or natural cycle, right? So if we are going for letrozole cycle, obviously we are looking for a follicle for the source of estrogen, right? For the endometrial development. So obviously, when we want to take the decision of transfer, we on the day of, before giving the trigger, we look for the progesterone. So in the presence of follicle, my cutoff is 1.5 in FET cycle.
Okay.
But if it is a HRT cycle, normally if the both the ovaries are quiescent, there is no activity, then I don't go for a measurement of the progesterone. But if at all some follicles are erupted, which is, you can say, escape, which happens in 6% of the cases.
Yeah,
So if
escape
this
happens.
any of the follicle is more than 10 millimeter, then definitely I measure serum progesterone level. And second, when unexpectedly or what do you call unexplained way, the endometrium becomes hazy or type 2, then I do measure serum progesterone level just to know whether how this endometrium has the texture has been changed. So these are the only two occasions where I measure serum progesterone level in FET cycle. Uh, uh, Dr. Sachin, if you want to add something.
Yeah, exactly the same values. Only thing is that my cutoff before starting progesterone in FET is less than 1.
Yes.
And I would also do a serum progesterone ideally on the day, or if not on the day, one day
A
before
day
the
before the.
transfer.
Yeah, that's
One day
true.
before the transfer. And I would like to have a serum progesterone of more than 12 ideally.
Yes. So Dr. Sachin,
So one thing, I'll just compile the answer of the first question, Dr. Seema. So probably when you think of doing a FET cycle for a patient, as by the our experts, for all the PCOS, they would definitely go for freeze-all. In normal ovarian reserve patients, if the follicles have come up more than 15, they will go for freeze-all. And yes, hormonal value not necessarily need to be checked, but if we do check, then E2 more than 1800 and P4 in general, when all of them have said more than 1.5 is the one where they go for freeze all. Besides that, any genetic test have to be done. For elderly females, if you have to do NSCS or PGTA on the embryos, and we are doing it for the freezing and then transferring later for any reason, for the patient's reason, then we do for freeze all technique. And yes, as Dr. Rajesh said and Dr. Seema said, most of us now follow freeze-all, maximal patient, only in few cases where we think that transfer should be done fresh, then we do transfer. And then while doing the transfer, it is good if we can have the hormonal analysis to tune a better result for the cases. So this is what is the take home when it comes to how to decide for FAT cycles.
Yes, Ekika. This was for the higher side of the numbers. And every expert about poor responders.
Yes.
To take the view of Dr. Rajesh, Dr. Sachin, and Dr. Anupma, that suppose a patient who is got 3 oocytes, we made 1 or 2 blastocysts. Now, what would be your protocol? Are you going to do a fresh transfer? Because I don't get results in fresh transfer, because I follow the same principle as Anupma said, ki E2 going beyond 15 to 1800, or in this case, as per follicle से ऊपर जितना भी जा रहा है, that is going to make advancement of the endometrium, that window is going to disrupt it. So why people want to do fresh transfer for poor responders, just to decrease time, decrease cost, or our aim should be to give a best cycle? Transfer, we might not be having the blastocyst, and we will, how will we face the patient? My question is, a day embryo which is not culminating into a blast that is hardly going to give pregnancy. It will be a difficult counseling, but what protocol are you doing? Fresh transfers, or are you following like me, freeze all and doing FET cycle for them too?
So the criteria remains the same. The only uh, uh, the change is a cutoff, because ultimately what is more important is progesterone per follicle. That is most important thing, because suppose there are 3 follicles, then for 3 follicles even progesterone 1.1 is also quite high. It's 1.1 is quite high. So, so I need to change the cutoff. That is one thing. Second thing, what is my worry in a poor responder? Normally, their gonadotropin consumption is quite high. So, if the gonadotropin consumption is quite high, obviously the progesterone level is going to be high. So, practically also, if you keep your cutoff low in case of diminished ovarian reserve, or you can say lesser follicle output, or then otherwise also you will not be able to transfer fresh. So you're rightly saying the strategy of transferring freezing embryos and transferring later on in poor responder is not a bad idea, and that should be followed. I agree.
So I think once we have reconciled this thing, I would like to move up to the second question, which is,
Madam, can I add one thing?
yeah, please.
Ma'am,
Please.
there have been some questions.
Another
Yeah.
indication for freeze-all would be a slow-growing blast.
Okay.
Yes, yes. Slow growing blast will be definitely from the embryology part. Will be
Can you tell something more about this, Dr. Anupma?
So suppose on the blast forms on day 6. Transferring fresh will not be done, because endometrium will be 1 day ahead. So there will be a asynchrony between the embryo and the endometrium.
True.
So there
if we
is a
don't-
question. Yeah.
Yeah.
There's a question from the
I think
audience.
Anuradha, this will be answered once they will answer the second the
Actually,
second
this
question.
is related to this, no?
I think it will come with the second question, the patient profile and the
Yeah, it
selection.
will come. Then you
Yeah.
take it with
Yeah,
that.
then we'll take it. Which protocol to select according to the patient profile? Now we have decided, we have stimulated the patient, we have frozen all the embryos, and now we are about to start the cycle. So 2 things which I want from all the experts: which protocol you will decide for the frozen embryo transfer. I mean, will it depend on the patient's profile? And secondly, what is all that you will do on day 1 of the starting of the protocol, and how will you proceed? That is what we want to know. And then we will ask the rest of the questions which are coming up regarding the sequence to be followed for the protocol of fresh embryo transfer. So, sir, we would like you to.
I will be last, third.
Okay.
First.
Okay, Anupma, then please give the now you have to decide. This patient has a frozen embryos. Now you have to start do a frozen embryo transfer. So will you do a HRT cycle, which you do a modified, or which you do a natural cycle, or do you do one thing for everyone, or do you decide it according to the patient profile? Okay, in this patient, HRT should be done. In this patient, I can take a letrozole stimulated frozen embryo transfer, or this is I will just wait, let the follicle come up, and then I will transfer. What is that you follow, and what should be done?
I will see her records, madam, and if previously if she had good follicle in a natural cycle, if they have done IUI previously, if she had good natural cycles, or then I would go for a natural cycle FET, or if she was anovulatory, then I would go for a stimulated cycle, and only for a perimenopausal women or premature ovarian failures, only those cases where we don't have any follicles in the ovary, I would go for HRT.
Okay. So in your practice, you do HRT only for the perimenopausal or POI patients, and rest of the patient you either do letrozole or natural or the modified natural. That is
Yes.
what you do. What is about Dr. Sachin?
Ekika, I
Yes,
have one question. Okay. My patient comes from London for an embryo transfer. What protocol should I use? Dr. Rajesh.
Any
Limited time.
Yeah, any batch work or any precisely if you want to have the transfer, if you want to fix up the transfer in particular period only, then there is no option but HRT protocol.
but HRT cycle.
Yes. So
Yes.
I have one patient who keeps coming and going, and I do HRT. So I just wanted to know from you. Thank you.
So, Sachin, Dr. Sachin, are you there?
Yeah,
if you
yeah,
can
yeah.
comment what is
Yeah,
that
yeah.
you follow? Yeah.
Hi, am I audible?
Yeah, you are definitely. And background is also very colorful.
Thank you so much.
Okay.
Okay, so my first choice of protocol is going to be letrozole stimulation. When natural cycle transfers came, I tried doing that, but there is a lot of blood work, lot of follow-ups that is required. So if this woman is a ovulatory woman, she is developing even one single follicle, I would always start with the letrozole protocol. Only if the letrozole protocol has failed, or if she does not respond to letrozole, if she's perimenopausal or menopausal, then I will probably go for a down-regulated estrogen cycle. Otherwise, there is no the third protocol for me.
Sir, now we would like to ask you your experience and what is that you
Can I
follow?
share? Can I share? Please allow me to share something.
Okay. Bhavna, sir would like to have a skin share. Dr. Rajesh, please give it to him.
Yes, sir, you are co-host now. You can share your screen.
Okay. Listen, I want to share the screen. So, okay, this started. No?
We are unable to see.
Yeah, I have to not delete it. Okay, usually. Not scanning. Can you see?
Yes.
Yes, sir.
Okay, sorry, it's handwritten, but this is what I do. So when it comes to endometrial preparation, there are certain things which I would like to know. That is, first thing is endometrial. What was endometrial thickness when stimulation was going on? So if you were knowing that the endometrial thickness was adequate, so at least I'm sure that I'm not dealing with the thin endometrium. Then definitely I will pay very large attention on TDS, because if intracavitary lesion is there, then first histoscopy to be done. If there is a congestion, tenderness in the while doing transvaginal sonography, if you float in the pouch of the glass. So probably I'm dealing with the chronic endometritis or something. Then I would give a doxycycline and clindamycin for at least 10 days, prebiotic, probiotic for 15 days. I would understand that this patient might require the higher progesterone dose because they have progesterone resistance. And not only that, these patients have higher uterine irritability. So I will understand that this patient before transfer will require atosiban. If it is adenomyosis or endometriosis, which is documented while doing transvaginal sonography, I will definitely go for down-regulated HRT. Or if it is a milder one, then I may go for letrozole. Uh, Second thing, I will understand that these patients, because of the inflammation, the progesterone resistance is there, so they will require higher progesterone dose. And not only that, they will require etostiban also. Uh, if we are dealing with the adenomyosis or endometriosis, I would be hesitant to start with the higher dose of estradiol because estradiol may exacerbate the lesion. So I would like try to keep the starting dose as a lower dose of estradiol. If it is a vaginal health is not good, then definitely prebiotic, probiotic. If the patient is obese, then their higher progesterone dose will be required. I will understand. And estradiol, I will not go by oral route. I will prefer to have a parenteral route, maybe cutaneous route, maybe vaginal administration. If it is a liver disease or metabolic syndrome, then also same parenteral route will be preferred of estradiol, and I will add low molecular weight heparin along with that in end of my HRT cycle, HRT protocol. If there is a miscarriage, then I would add low molecular weight heparin intralipid. That's okay. Now coming to choice of protocol. So uh, I prefer letrozole or modified natural cycle in all the time, all the time. That's my first protocol. Except as Madam Anuradha Madam said, when I am in tight situation where I am going for vacation or patient has come for a limited period, so I have to do that patient finish in the batch. So if it is a batch, then I cannot do a letrozole cycle. Second thing, when there is a cycle length is short, then letrozole cycle sometimes becomes difficult because follicle is recruited and the endometrium is still not grown. And then by the time has grown, the follicle becomes 23, 25 millimeter, 26 millimeter. So that becomes a risky game in letrozole protocol. Third is the PCOS. In PCOS, I am little hesitant to use letrozole protocol for the simple reason that these patients are oral drug resistant many times, and they need gonadotropin supplementation. And if I'm supplementing the cycle with the gonadotropin, if it is a milder dose, then it's fine. But if the follicle is not recruited even with the milder dose, then if a step up is required, then all the advantages of letrozole cycle is gone, and that becomes like a stimulated, I mean, a fresh cycle only because of the supraphysiological higher level of estradiol. So this is about the letrozole. Now HRT protocol is preferable when it comes to a severe adenomyosis or endometriosis. When I'm doing planning for batch work, it is short cycle, PCOS, PID. Why PID? Because PID is inflammatory, and HRT cycle is a good alternative when if you want to if you want to reduce the inflammation because it reduces the inflammatory cytokine. So in such patient, I prefer HRT protocol. And last, I use tamoxifen invariably when I am encountering a persistent thin endometrium. But I have to make sure that there should not be adenomyosis because tamoxifen produces a local estradiol. Aromatase expression is increased and local production of the estradiol is increased. So I would not prefer it in adenomyosis. So this is about the choice of protocol.
Okay, sir, then can you explain how you proceed with the letrozole protocol and how you proceed with the HRT protocol? So if you decide for the letrozole protocol for a patient, what is that you look for? I mean, you start on day 1 or day 2. Do you do any hormonal test? till how long you give, till what the follicle size when you give SCG. I mean, what you do till the time you transfer the embryo, and when you start the progesterone, how you count the days, whether it is day 0 or day 6. Because one person has asked a question, that is Dr. Ravindra. He asked,
Hmm.
in letrozole stimulated frozen endometrial transfer, how to decide day 1 of progesterone. So I would like you to please explain the letrozole cycle which you follow, and when you start the progesterone, and how you count for the transfer of day 5 embryo, how many progesterone injections to be given. That is what people always get confused, ki how many injections, after how many injection I should transfer a blast. So letrozole protocol in full, and if you do any blood test before starting, at the time of the start of progesterone, or at the time of the transfer, if you do.
Madam, this answer will be too long answer. This will take 20 minutes.
Sir, in
This
short, if you just tell ki on day 1 you do this and then you wait. Achha, sir, I want to just, okay, I'll ask you, you just answer me. In a way, sir, you start a letrozole protocol on day 1. Do you do any test, any hormonal test before
no,
starting?
no,
No.
I don't do.
So you just look at the ultrasound picture. If it's a quiescent ovary and the
Hmm.
endometrium is thin, you start the letrozole. So
Letrozole.
when you call the patient next, when you start the letrozole, when you call
So
the patient next.
normally I give letrozole 2.5 milligram, 2 tablet at bedtime for 7 days.
Okay. And
Directly, I call the patient on eighth day of the. I mean, after finishing the 7 days course of letrozole. Then I look at the endometrium. I look at the size of the follicle. If the follicle is growing, it is recruited. What I'm expecting is the one follicle at least should be at that time more than say 10, 12 millimeter, maybe more than 10 millimeter. So
okay.
if the follicle is recruited more than 10 millimeter, sometimes it is 12 millimeter, sometimes it is 14 millimeter. But endometrium is lagging behind many times. So in letrozole cycle, uh, it is very important to understand that in letrozole cycle, if the endometrium is lagging behind, you have to patiently wait. Why? Because they initially there is a quintination of the estradiol. There is inhibition, aromatase inhibition. So the endometrium is deprived of estradiol. And as the follicle is started growing more than 10 millimeter, suddenly the estradiol start coming from the follicle. And because this endometrium is long deprived of estradiol, there is a very good response, rebound response of the endometrium, and within a short span, the endometrium start growing. So in letrozole cycle, you have to patiently wait. Now the problem is if the follicle is more than 15 millimeter, once reaches 15 millimeter,
Okay.
then anytime you can expect LS surge, you can expect untimely ovulation. So once they reach more than 15 millimeter, then you have to look for perifollicular vascularity. You have to call the patient daily. You have to explain them that if they face the symptoms of ovulation, they should report to us next day. So we look at keep watch on the peripheral vascularity, size of the follicle, uh, and simultaneously, obviously, the endometrium growth. So if you are feeling little insecure and follicle has reached more than 14 millimeter, then you can afford to add estradiol level or maybe sildenafil. Sildenafil can be added from the beginning, from day 8 only, but estradiol little late you can add. And somehow, if the endometrium is reached more than 7 millimeter, and by the time the follicle has LS surge has not occurred, then you would like to. I definitely give trigger. I do not wait for LS surge to happen. So when I decide that okay, this patient I need to give trigger in the morning, I measure serum progesterone level and serum LH level in the morning only. Then I call the patient. I call the patient in the evening or give parcel of SCG trigger. So invariably, without fail, at 10 p.m. they take SCG trigger. So the report of LH and progesterone may be available to me by that time or may not be available, may be available next day. Doesn't matter. I call the patient next day morning. So if by the time the report is in my hand, so if the serum LH level is more than 20, then definitely I am expecting a rupture next day only. And if it is less than say 13, then probably I'm safe, and I'm expecting the rupture maybe 36 to 40 hours. But still, if the patient is staying nearby, I call the patient after giving trigger next day morning and next day evening also, and next day, second day morning also, because I want to judge the exactly timing of the rupture. So if next day, suppose LH level is high and progesterone is less than 1.5, then most of the time next day late evening the follicle is ruptured. Whenever follicle ruptures, that is counting 0 hours as far as the embryonic age is concerned. That should be considered as a endometrial age is concerned. That should be considered as a 0 hours. Suppose uh, the follicle is not ruptured in 36 to 40 hours. I call the patient normally after 38 hours. And if the follicle is not ruptured, I start progesterone at that particular time, and endometrial age starts from that point of time. If the follicle is ruptured, then I am differing from most of the people. I never prefer to start progesterone immediately if the follicle is ruptured, because once the follicle is ruptured, that secretes 25 to 30 milligram of progesterone from that particular corpus luteum. So they don't need what I call progesterone supplementation immediately. And since we had given SCG trigger, there is a supraphysiological very high progesterone for first 2 days or first 2 to 3 days of the SCG trigger. So I normally delay starting progesterone if in case of documented rupture, I defer 36 hours from the rupture. So I start progesterone 36 hours after the rupture, and endometrial, endometrial age starts from there, and accordingly, I thaw the embryo and transfer accordingly.
Dr. Rajesh, can you stop this slide share, please, so we can
Yes,
see?
yes, surely. Sorry.
Dr. Rajesh, do you again repeat progesterone like after
I want
एक
to
मिनट
ask
बेटा
a question.
when do you do
stop sharing.
progesterone again? Like because you've not started exogenous progesterone after the rupture of follicle, if you have documented that. So
Just a minute, madam.
when would you do a progesterone in such cases?
Just stop
Sorry,
sharing.
can you repeat? Can you repeat, madam?
Yeah, so you've documented rupture and you said up to 36 hours you don't start progesterone, vaginally or injectable, whatever. But I would like to ask you, do you repeat a serum progesterone value, say after 36 hours or 1 day before trigger or something? Uh, do you do that in these cycles?
No. In frozen embryo transfer stimulation, letrozole stimulated frozen embryo transfer cycle, serum progesterone is measured just once on the day of trigger only. Once the ovulation is confirmed, there is no need to measure the progesterone. There is a abundance progesterone available in the circulation, and I need not repeat because that there is no other alternative. Corpus luteum has to secrete progesterone.
So, Dr. Rajesh, that was my question exactly. If we are doing an ovulation induction cycle for a patient, as I do, I'm doing a lot of ovulation induction cycle. But why to introduce exogenous progesterone to these patients? The beauty of this cycle is we are not pumping them with outside progesterone. One follicle is sufficient enough to secrete enough progesterone for this endometrium to hold properly and continue the pregnancy. So why do you add progesterone 36 hours to everyone? Like recently I started doing one or two patients of mine who had beautiful progesterone level, and their progesterone level is not going to match to our HRT cycle levels as well. We have to remember, even if 10 nanogram of progesterone is beautiful enough to give a pregnancy in a natural modified cycle or ovulation induction cycle. So one or two patients of mine, they did not conceive, and I get one progesterone on the day of transfer only. Morning I take the progesterone, I get the report within 3 hours, and then I thaw my embryos. So those patients progesterones were less than 10, and in these particular cases, result is yet awaited. I did call them third day of my trigger, or for 72 hours, roughly 72 hours, and got their progesterone done just to test, to see how are they behaving in general. And if their progesterone, I made a protocol that if their progesterone report is less than 10 nanogram that day, I'm adding intramuscular progesterone oil base. Otherwise, I'm not giving. So I just wanted to know what's the reason you are adding this progesterone regularly from 36 hours onwards?
Very interesting question. There are a couple of reasons behind that. The first and most important reason why I do that. If you typically measure the serum progesterone after SCG trigger, uh, the progesterone starts rising very rapidly 12 hours after the rupture, and within 48 hours, it becomes very, very supra physiological, very high progesterone level. And
Yes,
this progesterone starts declining from
48 hours
uh,
onwards.
nine, uh, sixth day of trigger, precisely sixth day of trigger, SEG trigger. That is 4 days after roughly your ovulation.
So that is the day we are
Uh,
transferring and we are giving
yeah.
progesterone again.
And by eighth day post trigger, post SCG trigger, by eighth day, the serum progesterone level is much lesser than natural cycle. So, which is a actual time for implantation.
Plantation.
So I need to cover. I need to cover this deficient window of lower progesterone level, which is actually implantation window. I do not want implantation to suffer because of the suboptimal level of progesterone. That's the first reason. Second reason, there are some good evidence even in natural cycle. Even in natural cycle, if you add progesterone just on the day from the day of embryo transfer, the results are much better in natural cycle.
Exactly. So that's my question, that we are already going to do the day we transfer, we start giving progesterone, and to just fill up this gap, you're absolutely right that progesterone dips in natural on day of implantation, that day 8 of this trigger. So as per Humayden's view, we should be using little bit of SCG more. So why don't you repeat SCG? Why do you give progesterone directly, as it is a natural cycle? Can we give?
Yeah, yes, that's a good. That is a good idea. If you keep supplementing a small dose of SCG, you can make the luteal support without
Yes.
progesterone-free luteal support. But the problem is we are not sure about the quality of the SCG sometimes because that consistency is not there. So we are always little bit worried about exclusive use of SCG, at least urinary SCG.
Sir, one thing which two people have asked, how you decide the day of transfer? So in the case of letrozole cycle, you said once the follicle has ruptured for 36 hours, you don't give progesterone and then you start progesterone. So if they have to transfer blast, should they count at the day of rupture as day zero?
Yes, the rule is very simple.
Hmm.
The endometrial age starts from first exposure of progesterone when there is a HRT cycle or the time of ovulation. That from that point of time, the endometrial age starts and embryonic age starts from the fertilization. So time of
Okay.
ICSI, you can say.
So probably, I mean, somebody asked the question how to decide day one of progesterone. So day 1 of progesterone will be your day 0 of endometrial cycle. That the day when there is a rupture, or you give the progesterone from outside, or maybe the day of rupture of the follicle, which is
See,
day 0.
day zero is always rupture. I may start progesterone little later, but
Eight.
endometrial age is already started when there is ovulation.
Yeah, so but not everyone follows. I mean, wait 36 hours. So they want to know ki if they have a trigger and now they are starting the progesterone. So should they call this as day 1 of the progesterone with day 0 of the
See,
endometrial
if
cycle?
in the absence of follicular rupture, if
Mhm.
you have started progesterone, then point of starting progesterone should be considered as a day zero.
Day 0. Okay.
And if there is a ovulation, then that point of time should be considered as a day zero. So I would recommend, I always keep telling, and those who are following me, that please stop talking about day zero, day one, day two, day three. We never use that vocabulary in our lab. Our embryos are 62 hours embryos, 68 hours embryos, frozen embryos. These are 72 hours frozen embryos, something like this. So we always match the exposure of progesterone to the hours of development of the embryo, and that makes our life quite simple.
And
Okay.
Rajesh, one of your lecture, I heard about this and I started following the same. And the best thing was that last injection of progesterone, say 4 hours, udhar jagar ke karne ka. And I really felt the difference, and that was
Yeah.
really good.
Thank you.
Okay. And
So,
there is
and
one
for
more
the
question, sir.
beginners,
Patient has
for the
asked.
Ekika, I just wanted to clarify for the beginners who are doing letrozole cycle, the day of SCG low और उसका third day is OPU day, no? किसी भी trigger का. So that could be the first day
day
zero of
0.
progesterone.
Day 0 of
तो
the
and you
progesterone.
have to count it 0 plus 5. तो 6 दिन 8 दिन बाद ट्रांसफर करना है अगर आपने SCG लगाया तो.
SCG लगाया उसके 8
तो
दिन बाद, और अगर रप्चर हुआ है तो
blastocyst,
उसके 6ठे दिन. हाँ, ब्लास्ट के टाइम से.
blastocyst. Yeah.
So this is what one must keep in mind कि अगर आपका SCG ट्रिगर है तो उसके 8वें दिन, और अगर आपने ओव्यूलेशन देखा है मतलब उसके बाद जो है देन उसके आप 6ठे दिन ट्रांसफर करेंगे. Sir, one more question is there. Does high basal LH matter in modified natural or HRT FET cycle?
If the progesterone is, see, basically we have to understand uh, the endometrial age starts from the exposure of the progesterone and or ovulation. These are the two things from where we can count that the 0 hours of the endometrial age has been started.
Yes.
It has never mentioned that LS surge can decide the endometrial age. No, LS surge cannot decide the endometrial age unless there is a documented ovulation.
So
Many
basic
times,
LH.
many times, the LH is elevated, but ovulation is not happen on next day. It happens 36 hours after only, even if the LH is elevated. So we cannot rely on LH to
I think they are
decide.
asking about
That
basal
day 2.
LH.
Day 2 LH, sir.
LH.
They say if the day 2
And that
LH is
doesn't
high.
make any difference at all.
Yeah, that doesn't
Sorry,
make any.
sorry.
Day
Yeah,
2
so you're
LH.
talking about day two?
Day 2 high
Yeah.
LH. Does it make
Day,
any difference in FET and letrozole cycle? Day 2 LH, sir.
uh, no,
No.
I don't
And
think.
Dr. Sachin, there is one question. I mean, because you spoke about the progesterone level. If progesterone is less than 12 on the day of transfer, will you increase the dose of progesterone? And if we increase, will it affect the success, or do we need to cancel the cycle if P4 is less than 12? Dr. Sachin,
Fantastic
what is your
question.
take?
Fantastic question. So, I was just listening to all the deliberations that were going on, and it has happened to me a couple of times that on the day of transfer, the progesterone has comes 8 or 9. Now, at the last moment, what do you do? Do you give a serum, give a IM injection of progesterone, and then do a transfer tomorrow? But then you are like, the progesterone is just getting elevated one day prior, and it is not affecting the endometrium over a period of time. So to counteract this problem, I have made the letrozole cycle, very simple, which I shared with a lot of colleagues as well. What I do is I will start with letrozole 2.5 daily. Once the follicle begins to grow in size, we will see for the endometrium to grow beyond 7 millimeters. Once it touches 7 or 8 millimeters, you will usually find the follicle to be in the range of 16 to 18 millimeters. तभी आपको क्या करना है, रात को 10 बजे give HCG trigger, but in the morning do a serum progesterone on the day of trigger to ensure that progesterone elevation has not occurred. It should be less than 1. ठीक है? I have an in-house mini Vidas machine which my lab techs are trained that progesterone, beta HCG, AMH, these 3 levels they have to process on an urgent basis और 2 घंटे में मुझे report आना चाहिए. So all practicing IVF practitioners, I would suggest to have a mini Vidas machine. It's not a very expensive machine, but it makes life very easy. That is one thing. Secondly, रात को 10 बजे is the fixed time for trigger without documenting follicular rupture. After 36 hours, patient does not come to me. She will start with progesterone, dydrogesterone, and natural micronized progesterone 10 a.m. after 36 hours. If I am doing a blast transfer, patient will be given progesterone for 5 days and 6th day will be the transfer. With this protocol, very rarely have I come across a patient whose serum progesterone is less than 12. And that is the reason why we hardly ever have to cancel the cycles, the FAT cycle. Now, as Rajesh sir and Dr. Seema said, it is very physiological, but trust me, their knowledge of understanding of endocrinology is way beyond ordinary mortals. So I have protocolized, as Dr. Seema, read my CV. I also do obstetrics, laparoscopy, IVF, everything, and I'm also a pro trader. So ये सब में बहुत ज्यादा individualization नहीं करना है. It has to be protocol based, and that has worked.
Now
Sachin,
The
my
question
apprehension.
I wanted to ask you, Sachin, is like if the on the day of transfer, the progesterone level is less than 12. So do you give more progesterone and proceed with the transfer, or do you cancel?
I would
I
ideally
can
cancel
ask.
that. I would ideally cancel the
Cancel.
transfer
Okay.
because I have.
Sachin, can I ask one question? Yes.
Sure.
So this is a modified natural cycle. You are giving oral and vaginal progesterone. So why do you expect your in this serum progesterone to go beyond 12 nanogram per ml?
Sometimes it does occur that even with all these protocols, the serum progesterone rarely does not cross 10.
So there are two part of my question. This is first part. Yeah. So you cancel it when you get it 10 or 12, below 12.
Right.
Okay,
Below 12.
that is your experience. Okay, coming back to fixed protocol. So if we stick to this modified ovulation induction cycle with SCG trigger, so simplest way is that if we give SCG trigger in the night at 10 p.m. and as we count our things, or either we confirm the rupture or we count the hours as we count it for the pickup. And why don't we start do transfer on day 6 without giving progesterone? Like I'm doing letrozole cycles, believe
Dr.
me,
Seema,
jinko cycle mein I'm not.
your voice was had gone some time back. Can you just repeat
Okay.
your
So
comment?
I'm saying, why to add progesterone, so much progesterone if we are doing letrozole cycle? Like I'm getting very good results without adding progesterone to in more than 90% of letrozole cycles. And our aim is to decrease these extragenous hormones as much as possible, be it estradiol, be it progesterone, so that patient perinatal complications, epigenetic changes that enforcement of placental and endometrial tissue, and those things we can improve for this fetus. So, as far as my understanding, if first cycle we are going to do the transfer, and if we are getting very good follicle, we have given SCG, we are doing single embryo transfer, then without progesterone we can go ahead.
I would be
Can I,
very apprehensive. Yes, sir, Rakesh sir, please go ahead.
Dr. Seema?
Yeah.
Okay. So you ask why progesterone should be given. Now the fact is very well known that ovulation does not guarantee a corpus luteum defect. Do you agree?
That's true.
Yes,
Even
I
nature.
do.
So you are never
Yeah.
sure that after ovulation, documenting ovulation, if you do not give progesterone, this cycle is not going to be progesterone deficient because certain ovulatory cycles are corpus
No.
luteal
That's why we are
deficient.
measuring progesterone, Dr. Rajesh.
Sorry.
That's why we are doing the measurement of progesterone, no? Whether this corpus luteum is functional or not. What all I mean to say,
Second.
if your level is without giving anything from outside, your level is up to 10, 12, there are good chances that you get pregnant. Anything beyond 8, I've got Beckman Coulters, and 8 nanogram ke upar jitna bhi progesterone we are getting, and we are getting pregnancy in majority of those cycles with letrozole. That's what I just wanted to convey. It was a discussion, so I am bringing this point to make the cycle simple.
Absolutely, I totally agree. In fact, there is a one study, and in that study, how they do, they withdrew the progesterone support, and they keep measuring the progesterone. And the moment in during luteal phase, the moment they noticed the progesterone levels less than 10, they started supplementing, and still they have shown that results are not that compromised. So I totally agree. If progesterone level is adequate, there is no need for a supplementation of the progesterone. Now, second reason
Good.
why I want to supplement, I am little liberal, and the world is little liberal about the supplementation of the progesterone. See, we all are worried about the supraphysiological level of the estradiol. We are not too much worried about the supraphysiological level of the progesterone because still the conclusive studies are yet to come that which
Those
is
findings.
the highest level where progesterone is harmful, because there are studies that if it is more than 100 nanogram then it is harmful. There are some studies says more than 30 nanogram at the time of ET it is harmful, but there are studies which says that if you use 600 milligram of vaginal progesterone, but instead of that, if you use 1200 milligram of vaginal progesterone per day, the results are still better. So really, we are confused. We do not have adequate evidence. What is the higher cutoff? What is the higher cutoff of the progesterone level? So we understand that rather than keeping tension in mind, better to supplement progesterone. That is not going to harm. That's the whole
Agreed.
idea.
Agreed.
So
Agreed.
actually, the
Yes.
take-home message which I want to conclude from everyone, because I'm
Anupma,
interrupting you, ma'am. Yeah, Anupma, I really want a two short line verdict from you about this letrozole cycle, and I'll conclude everything because this is really huge, vast topic, and I would like to, compile everything what Dr. Rajesh, Sachin, and Dr. Seema said. What is your take home message for this letrozole cycle? Do you give
Only
progesterone after the trigger?
single, only single question I want to ask Sachin. Sachin, your simplified protocol, that's fantastic. And most of the place it works. But only a single question I'm asking. You are not measuring serum LH level on the day of trigger. You are just measuring serum progesterone level. Suppose the next day rupture unknowingly happens in the morning only after triggering in the night. Suppose you are riding on the LS surge and suppose there is a rupture on the next day morning only, whereas you start progesterone after 36 hours after of your trigger. Will will it not be disturbing the window of implantation, because your calculation is going to be 1 day shorter as compared to the rupture, because the most important is rupture. Once the rupture is happened, that should be the endometrial age 0. What do you say?
Superb question, sir. I was expecting somebody to ask that. So what I do is not only the follicle and the endometrial thickness, I also look at the quality of the endometrium. It has to be nice trilaminar. Whenever LH surge begins to occur, we will see that at the endometrial myometrial junction, that is the place where the first haziness is going to occur. And as you also believe, and I also do in my clinical practice, I will not wait too long for the follicle to grow 18, 19, 20. Once the lining is 7 millimeters, good trilaminar with the endomyometrial junction showing no haziness. If there is slight haziness, I will definitely do a LH along with serum progesterone to determine whether the LH surge has occurred or not. And in majority of the cases, I have seen that the LH surge has not occurred. So that is when I will give my trigger and go ahead with the transfer. Now, second question. The window of implantation in a estrogen cycle we usually follow is 6 hours, means 3 hours plus and minus
3 plus
after 3 hours plus minus after 120 hours of starting initiating progesterone. While in a natural cycle and a modified natural cycle where we use letrozole, because of corpus luteum, the window of implantation is very wide.
it's
Agreed.
extended. It's
It's
Agreed.
extended.
very wide. So
Agreed.
वहां पे 8, 5, 6 hours, 10 hours really does not make a huge
Probably it
difference.
is plus minus 1 day. If
Probably
Completely.
plus minus 1 day. Correct. Correct.
Yes.
Correct.
Yes, that makes sense. Yeah.
yeah.
That's
So
the
Anupama,
additional
anything
beauty
you
of
want to
this.
add? Dr. Anupama, anything you want to add?
If you have given a HCG trigger in a stimulated cycle, that will suppress the natural LH pulses. So by the time of implantation, that is 6th day or 7th day, the progesterone levels are going to fall. So we will need a LPS if a HCG trigger had been given. If it was a natural cycle, natural ovulation had occurred, then the LH pulses are intact and the progesterone levels are maintained. So if it's a stimulated cycle and a HCG trigger has been given, LPS is a must.
Okay. So to wind up the session, I want to say to everyone, uh, when you give the trigger, after 36 hours, if there is ovulation, you can wait for 2-3 days and then start estrogen, then start progesterone injection, as Dr. Rajesh said, to counteract that LPS which might occur, and then transfer accordingly. The way we say, the day of ovulation will be the day 0 of progesterone, and if you are transferring the blast, then it will be on day 6, day 0 plus 5 injections of progesterone. And as Dr. Seema's experience, not everyone has the facility to check the hormonal values all the time, and a good, like ma'am, you have Beckman, which is absolutely a delight when it comes to
Not about Beckman, Ekika. It's about the physiological fact that when this is a natural cycle where you are giving an SCG trigger, SCG has a longer half-life to cover for that corpus luteum deficit, which is occurring or dipping on day 8, that is being covered. And once we do the embryo transfer, we are starting our luteal phase support and we starting just giving pumping progesterone from all the parts. I find it very simple. I give it and it is tried and tested. That's why I said it's not
probably
about
yeah, okay, no, but probably everyone would love to know the, because it's the embryo transfer and every patient has put up so much of it, and even we are very anxious. We would at least, if we know the level of the progesterone after the trigger, I mean after we have given trigger, then it is something, okay, I'm happy that okay, it is good, and then I can transfer. Otherwise, as madam said, in her experience, you see a good ruptured follicle and you have given an SCG trigger, then you can go ahead and transfer counting the days without progesterone supplementation during that period, and then you can follow the luteal phase support. But as everyone has said, it is good.
just I want to add, don't take it otherwise. Giving progesterone, as Dr. Rajesh said, there is no maximum dose or minimal dose finding study for progesterone. If you are giving, you are not doing anything wrong. This is
Yes.
the way it works for me.
So,
Can I add one more point about progesterone here?
yeah, please.
Progesterone, as we know, has a uterotonic, a uterine calming effect. So when you have a lady whose serum progesterone is very low, you might find some contractions occurring
On
at the
the day of
level of the
transfer.
endometrium.
Yeah.
And then you would want to give her retoseban and sublingual piroxicam, etc., etc. While if you have given her a adequate progesterone right from day 0 or day 1, I also don't get into that calculation. It's very confusing. You will find a good serum progesterone level and the endometrium, which is almost quiescent or a dead endometrium. There is
Definitely.
no waves that is occurring. So that is the reason why I would like a slightly higher dose of progesterone compared to a lower dose of progesterone. And I mean, a lot of things about calculation. So like, can I just add one line of uh, timing for the audience? मंडे को रात को 10 बजे ट्रिगर देना है, वेडनेसडे को सवेरे 10 बजे विदाउट चेकिंग प्रोजेस्ट्रॉन, विदाउट चेकिंग फॉलिकुलर रप्चर, प्रोजेस्ट्रॉन चालू
Progesterone
करना
should
है,
be.
और मंडे को सवेरे 10 बजे ट्रांसफर करना है अगर ब्लास्टोसिस्ट है तो, अगर क्लीवेज सेल है तो सैटरडे को ट्रांसफर करना है. सिंपल.
So, I think this clears
Excellent.
all the questions which somebody asked. How many hours later do you start progesterone after rupture? Immediately, or as sir says, after 36 hours? Do you add progesterone on the day 4, 5? Yes, it is being added. And if P4 is less than 12 on the day of transfer, what extra should be done in next cycle? Now, if you found that people who do P4 on the day of embryo transfer, Anupma, I want to ask you, if you find the P4 is less than 12 on the day of the transfer, and you have planned to cancel the cycle, now you're going to take this patient next time. Will you do anything extra, or will you think of supplementing more progesterone? What is that you follow? And then, in short, I would like everyone to give one line for this.
Madam, this cycle only I would rescue it with one more progesterone dose and then carry on. I wouldn't cancel the cycle.
Okay. So, what is that you will add? How much progesterone will you add? I mean, if you find it is less than 12 and you have transferred the embryo, so which progesterone will you give? And will you continue it for the 12 week, I mean the whole time before checking the beta HCG?
I would give 50 to 100 milligram of intramuscular progesterone, ma'am.
Okay, intramuscular progesterone. Sachin, what you will do to, I mean, if you want to rescue the cycle, I mean, if it is less than 12, what will you do? Will you cancel or will you add progesterone and still transfer?
Given a choice, if the patient is compliant, she's not come from London, then I would probably cancel the cycle.
Okay.
But if she's come from London, then I will probably give her injection IM 100 milligrams and continue it for 3 days minimum. And
Okay.
then so that it will take for some support.
सचिन, ये तो तुम्हारा लेट्रोजोल साइकिल है, उसमें 12 इतना बढ़िया आया है तो क्यों कैंसिल करोगे? बोलो.
12
अनुपमा,
नहीं
नहीं
आया
नहीं,
है
12
मैडम,
से
तो
कम
प्रॉब्लम
बाबा.
है ना.
इट्स लाइक अगर 12 से कम रहता है.
अरे
So,
10, मैं एक चीज, I
okay.
just want to add one thing. If it is a natural cycle, don't expect more than that. And if it is an HRT cycle and you are using only micronized and oral progesterone, you will not be getting very high level of serum progesterone.
You will
So
not get.
there also 15, 18. Only people like us, me and Anu, we do oil-based progesterone injection before transfer, only oil-based progesterone we give. And मेरा अपना maximum pregnancy rate is when it is beyond 35 nanogram per ml. That
Yes.
is my lab ka association. Fine.
So that
But
is
if
true.
you are giving micronized and this 20 तक जाने पे बहुत खुश रहो बाबा, इससे ज्यादा नहीं मिलना है, because that's not going in serum, it's going directly to your endometrium through various routes.
Dr. Seema, so you give serum injection progesterone daily or every third day?
Daily for 5
For 6
days
days.
before transfer.
Okay, so
I don't give anything else.
no vaginal, no
No,
dydrogesterone,
no,
nothing.
In
nothing.
HRT cycle, only
Only
IM
IM progesterone.
milligram progesterone.
And
Nice.
Dr. Sachin, it gives very good values. I mean, only IM progesterone, that what even I follow for my HRT cycles. You give this, you will definitely get the value above 30 in most of the cases, very steady values. And then we transfer. That is what even I follow. And as she said, yes, when you do give oral and vaginal progesterone, the values which we get, the blood values which we get, they are not correct because one of them is not being detected. So probably there is always a doubt, some doubt whether we should increase the vaginal or whether we should increase the oral. So for this 6 days, oil-based progesterone, I mean, that is what even I use, which gives the value mostly in the range of 25 to 45. And yeah, it is a bit painful for 7 days, but it gives a very steady value and a very good result.
So aqueous वाला या अपना देसी पुराना वाला?
नहीं, oil
Purana
based
wala,
one is
oil
good.
based. That
Purana
is what we
wala.
use.
No, not the aqueous one.
I
No.
tried aqueous pre-transfer, but it did not work as oil-based work. Maybe I'm biased.
Maybe we are biased.
No,
Yes.
actually, I'll tell you, we men, we sympathize with the women a lot more, and that is the reason we look at their pain factor and all that.
Me too. But you know what? Once I tried to replace it with 50 aquas and 2, 3 patients, and I didn't get good value. And then post transfer, I am a biggest believer of serum progesterone level maintenance.
Yes.
So I give post transfer also, but that is converted to aqueous one. Only pre transfer, I have this religious belief
Yeah.
that it should be oil based.
Okay.
Very truly, Sachin, it is very difficult for us, at least even for me, to really turn it out to aqueous because it gives such a good result. And sometimes okay, this is working, and our females are very, very cooperative. So they take this pain, okay, because this is for their good. I know it is like 6 days painful injections, but then
Yes.
it gives result. So probably
Somebody
before
is
ending this FET, ma'am, I think we'll have to move for the next one.
Yeah.
somebody is asking
Yeah.
whether I give luteal phase support or not after this SCG injection. Yes, definitely.
Yes.
We are giving proper, and it has been proven even in TIC cycle. If you are doing with letrozole for PCOS, you need to give good luteal phase support that has been supported by evidence-based RCT2. So this is an embryo transfer cycle. So we believe in pumping progesterone from all the routes possible.
So there are two questions which I think will go with the next topic of ours. So we will cover that during those things. So to compile, I mean, we have done a lot of about letrozole cycle. For HRT cycle. I really want, I would say the thing which we do at our center, if we are taking the patient for HRT, most of them are menopausal or POI or even in severe PCOS, where we really think that inducing them with letrozole might not give us a good follicle. So we take them for HRT. You can do a basal day one hormonal test, and even you can't do if you see everything is in uh, a normal state, a docile state. We start 2 milligram BD estradiol, and we take it till day 12 or 13. Till the time we see the endometrium thickness, for us it is more than 7.5 or 8. So on that day we decide to start the progesterone, and on the start of progesterone on the 6th day we transfer the blast. This is what we simple thing which we follow, and it can be to to garnish it or to have a better result. We can add the hormonal levels on day 2, on the day of the start of the progesterone, and on the day of the transfer. So probably all of you in short, if you can explain, do you do the hormonal levels on the day 2, on the day of the start of progesterone, and on the day of the transfer in the HRT cycles also? So simple, quick take home what you do. I'll start with Rajesh sir, and then Sachin, Anupma, and Dr. Seema.
Regarding
HRT cycles. Do you do hormonal levels on these days, day 2, when you start the progesterone, and the day of embryo transfer in HRT cycles?
no, I don't do because a couple of times I did, but then I didn't found any case where the progesterone level was suboptimal because I start injectable progesterone right from the beginning along with the dydrogesterone. So I'm pretty sure about the adequate progesteronization.
Okay. So probably in this, the whole cycle is in our hands. So according to Dr. Rajesh, there are no need to get a lot of hormonal levels done. So what do you say, Dr. Sachin?
No investigations on day 2 to be done in a FET cycle. The
Okay.
only investigation to be done, whether it is modified natural for letrozole or estrogen or a downregulated hormonal, is a E2 on day 2 if there is a follicular recruitment. Otherwise, no investigation to be done. Serum progesterone before trigger in the letrozole cycle, serum progesterone before starting progesterone in the estrogen cycle to ensure that progesterone is less than 1, and serum progesterone ideally 1 day before the transfer to ensure कि 12 के ऊपर है, बाकी no other investigations.
So what do you do, Dr. Anupama?
In HRT, nothing, madam.
In HRT, nothing. So somebody wanted me to sum up the whole FET cycles. So it is done either with letrozole, modified stimulated cycle, or the HRT. With letroz, if you start, once you see the follicle in a enough state, when you have to give SCG, a SCG trigger is given. And after SCG trigger, you look for the ovulation 36 hours later, and then either you start the progesterone on the very same day, or you can start the progesterone 3 or 4 days later and transfer accordingly the way it is said. The day of the progesterone is day 0, and on the day 6 the blast is transferred. In HRT cycle, it is very simple. You start estradiol from day 2, and then when the endometrium is good, you start progesterone, give 6 injection, and transfer the blast. So I think
I have one last question.
Yeah, sure.
Dr. Rajesh, what is the minimum endometrial thickness you have encountered and you have transferred and it has yielded a positive pregnancy? What is the minimum criteria? You are muted, sir.
4.5 millimeter.
Sorry?
4.5 millimeter.
Oh, you've transferred in 4.5 and you got a positive rate.
There was a patient.
But what is the general cutoff? Okay, this is occasional thin endometrial, maybe some reason would have been there. What is the general cutoff for your endometrium in a day?
Yeah. So if it is a fresh cycle, I keep cut off 8 millimeter. If it is a FET cycle, I keep at 7 millimeter.
Okay. Sachin sir, yours?
I had a patient who I myself had done laparoscopic adenomyomectomy 2 times. And every time the adenomyoma that was removed was bigger than the size of the uterus. Okay, and of course she was a very poor ovarian reserve, AMH less than 0.1. I tried giving her letrozole, but follicle did not increase and lining did not increase. Did all sorts of masala, this, that, everything, nothing worked. Then I did the ultra long protocol, gave her 2 shots of depot, and then started with estrogen. And everything, the lining would just not cross 5 millimeters. So I concurred with the patient, let's transfer, because we had never done the transfer. And at 5 millimeters, she conceived, went to term and delivered.
Wow. Anupama, Dr. Anupama.
7.
7.
Yes.
So, Sachin, one question comes to mind looking at this, and Dr. Rajesh and Anupma too. This adenomyotic patient, like this is traditionally we are doing 2 or 3 Leupliodex and we are doing Easter. What is your opinion or view? Have you ever tried this letrozole protocol for these patients, and how did they respond to it?
So sometimes if she is a ovulating woman, you will get a nice lining with letrozole. So, for me, any ovulating woman, as I initially said, my first choice would be letrozole.
Mine too, yeah.
I have a huge stake in companies which make letrozole. So I have come up with letrozole in all other indications. So my first choice would be letrozole. Only if she does not ovulate or she's failed a letrozole cycle, I will go to a estrogen.
And Rajesh? Adenomyotic patients, basically, because it has some therapeutic value as well. That's why I was asking.
Yeah, if it is most of the cases of adenomyosis, they are associated with some sort of pelvic endometriosis, and these are the patients where lot of cytokines are there in the uterus, as well as the peritoneal cavity also, and which makes the increases the progesterone resistance, makes the environment hostile for the implantation. So I was always like to reduce these inflammatory markers, and the only way to reduce inflammatory markers is agonist down regulated cycle. So in any case of adenomyosis or endometriosis, I always prefer down-regulated agonist cycle. Unless it is a very mild variety of adenomyosis, then I may go for letrozole cycle.
So my question was that only. Ki instead of Lupradex, have you ever tried letrozole
Yes,
for this case?
mild adenomyosis. Many times I've tried letrozole cycle. There is no problem.
Dr.
Even
And
I'm,
Siva,
second thing,
for
yeah,
sorry,
even
second
Dr.
thing,
Seema,
second thing, I am not too fussy about the endometrial thickness. I am not too fussy. Really, believe me. I go more by the vascularity. I go more by the texture rather than sticking absolutely to the thickness.
Yeah.
yeah, Dr. Seema, even I think, I mean, in cases of adenomyosis and endometriosis, sometimes exogenous estrogen might not give us a good endo, which we really want. So in these cases, I have seen if we give them a letrozole cycle, and one follicle is growing up, I don't know, endogenous estradiol gives a very beautiful lining. So letrozole should be the first choice when it comes to endometriotic or adenomyotic patients, and we are taking them for transfer. This is what I have seen.
Anupama, what is your view?
I'm always ultra long protocol in adenomyosis.
Adenomyosis, yeah.
Me too. I go with
When I am doing
related.
ultra long protocol for adenomyotic patients, I was talking about long-term letrozole therapy instead of
Oh,
Lupradex.
mm,
Dr. Sachin Kulkarni is
do this.
into it. So that's why, like, I've not tried yet. So I was taking your opinion if that any of you have
Ma'am,
used
there are
ever.
studies in which they use lipidox, I mean the agonist along with this letrozole. I mean both of
Yeah,
them
well, that is
together given for
pain
given for
score
3 months.
as per
Yes,
the pain
yes,
score. So I have used for
yeah.
perimenopausal family completed females with letrozole and Lupradex plus minus, but not for our embryo transfer cycles. Here we like to do either if it is mild adenomyosis, I'll go with direct letrozole protocol as per ovulatory cycle or ultra long protocol most of the time.
I would like to draw your attention. The protocol agonist down-regulated protocol, where along with the agonist letrozole was used. That was for unexplained implantation failure, not the proven case of endometriosis or adenomyosis. There is no additional advantage of adding letrozole to the agonist downregulation. There is no additional advantage.
No, no, no. That was for poor ovarian reserve patient, that protocol with Lupradex, letrozole, and later on Androtaz that did not work. I tried in 2, 3 patients. It's not about that. It's about taking care of adenomyosis. Letrozole has become among 3, 4 drug of choices for adenomyosis and endometriosis. Basically, for people who want good pain relief and cycle control. That is for them as it is. An aromatase inhibitor, and that is blocking the estradiol production. So few people are using it pre-transfer. That's what I wanted to know the experience. I'm not talking about that protocol for
Yeah.
increasing the number of eggs. We use letrozole and SCG and Lupradex for 25 to 30 days.
That's when the size of the adenomyosis is also greater when we add letrozole.
Pardon, Anupama?
The size of the adenomyosis, if we add letrozole continuously to an agonist, the size reduction of the adenomyosis is greater.
Is better. Yeah.
Fantastic discussion we had. I mean, this discussion should really be one of the best discussions on endometrial preparations ever.
I think Ikika and the whole of expert panel this session has extended, and probably recurrent implantation failure is a totally separate entity. We should take it, maybe split this discussion up. What is your opinion?
Plus one.
We take it next time, the RIF,
Yeah,
because
I
it's a
think
very huge.
huge. I think we need a lot of insight from all of you when it comes to RAF, and even there are few things which we would like to talk on thin endo. But yeah, I mean, it will be good if we take it in parts. What do you say, sir? Dr.
Great.
Rajesh?
I am with.
Ekika,
I am.
sir, एक मिनट. Ekika, thin
Yes.
endometrium is Rajesh sir's favorite topic. He can speak on thin endometrium for 2 hours non-stop.
So
Non-stop, only
I
Rajesh
think,
sir.
sir, I'll take your permission to keep one more webinar,
Hmm.
Two
specifically
more.
on thin. Two
Two
more. One is
more.
on
Two
thin.
more.
Yes, two more. One is on thin endometrium, in which we would like
And
you to
one on
even
RIF.
yes, you give a PPT also, a PPT presentation, and then the questions, and then we will do an RIF also.
No, no,
I,
similar kind of this.
I
We
think
want
this
to.
discussion was better than PPT, please.
Yes, exactly.
Okay,
Agreed. Agreed.
fine.
Totally agreed.
So
Plus
let's
Totally
one.
agreed.
Rajesh,
let us for
Seema
the
has started knowledge shots where we have discussion like this. We call experts and we discuss, and we have found it more interesting rather than PPT. Maybe one or two PPTs to explain to the crowd
yes.
a flow chart or something. But I think this discussion is like a boardroom
So
discussion.
then
Absolutely.
I think
I
I
totally
think
agree.
Dr.
sir. So I think
Anuradha
we
and Dr. Seema, probably you would not be aware. Dr. Rajesh single-handedly had a 2-day conference. It was a residential conference in Mumbai around 4 months ago. And from 9 o'clock in the morning to 9 o'clock in the evening on Saturday, and 9 o'clock in the morning to 6 o'clock in the evening on Sunday, Sir was single-handedly talking with other people, giving their inputs. It was a brilliant conference which was organized by Sir.
No,
Sir,
no,
next
I
time
was
when
no, no,
you do,
I was not. No, sorry. Sachin is telling something wrong. Myself and Sachin, we both were there. So we were
I know.
handling together.
Sir, next time when you do this, please हमें भी याद रखिएगा. हम भी आ
श्योर
जाएंगे.
श्योर. अरे आप हमारे छोटे, आप लोग तो बड़े लोग हैं. आप थोड़ी
सर
आएंगे
क्या
हमारे
आप
लपेटो लपेटो कोई
हाँ
बात नहीं.
हाँ okay
so
then
okay. Sir, then just before ending, there is one question which has come. So this is the final one, which we will end now, and probably for the two topics we'll keep again. And I'm happy that this is the first time ever I had thought of a small gathering where we can discuss academically. And yes, got wonderful inputs from all of you. So thank you very much, all of you. And before ending,
Thank you.
lining should be the question is the lining should be in coherence with overall uterine volume 2. Small uterus,
Very
small
good.
lining
very
is
very
all
good.
acceptable if trilaminar pattern is good. So
Perfect.
that's what some message is being passed. And yes, madam, GnRH agonist plus letrozole 2.5 for 3 months before transfer gives super results. So this is what even I follow. So
थैंक यू गाइस. अच्छा
so
Thank you
बता
so
दिया.
much.
मेरे को पेपर का नाम याद नहीं आ रहा था. And Dr. Sachin Kulkarni is my mentor. So he was asked one day, we were discussing and he said, you try this also. This gives better results. So I wanted to pass on. And thank you, Rajesh, Sachin,
Thank
and
you. Thank you all. Really
Today
It
is
enjoyed.
was
today is
brilliant.
the
Had a
we
second
great
day.
time.
enjoyed it. Let's
Today
do
is
it
the
more often. Let's do it more often.
Dr. Rajesh, today
Thank
is
you.
the second day in our series of webinars. One
Hmm.
was immunotherapy, where we didn't want to end that discussion. Second day is today with you all. That I really, I'm not fatigued. I'm so rejuvenated, and I want this to continue. But now it's dinner time for everyone. We conclude here. Thank you, Ekika and
Thank
Dr.
you.
Seema, for being a
Take
wonderful
care, yeah.
moderator. Thank you, Dr. Rajesh, Dr. Sachin, Dr.
Thank you.
Anupama, for your valuable inputs. Thank you, Corona Remedies, for putting all of us together, giving us this beautiful platform. And above all, when you have a good audience, such an interactive audience, your job becomes very, very easy and tough together. because they know the subject. So thank you, everyone. With
Thank
this
you.
promise, we'll meet up again to complete this discussions. Thank you so
Surely,
much.
surely.
Probably very soon we will come up with the two rest of the left topic, the thin endometrium and RIUF, and be ready with your questions, with your queries, because we'll come back again with our experts and have a discussion. And thank you very much, all of you. Thank you, Dr. Rajesh, Dr. Sachin,
Thank
Dr.
you.
Anupama, as being an expert, and yeah, Seemadi, a wonderful person. Anuradha, very nice to have you with me over here for the smooth
Thank
transition
you,
of the
Erika,
program.
for
Thank you.
arranging this.
Thank you. Thank you.
क्योंकि
Thank you.
राजेश मुझे तो
Thank you.
नहीं सर मैंने बनाया सर को कि आइए सर आइए
नहीं, नहीं.
Okay. Thank you, everyone. Thank you, everyone.
Bye,
And
good
let's
night.
are
have
we
Bye.
off air? Are we off air?